Edema. Today's topic will be on edema and approach to a child with Anasarca. So edema in children is an important clinical sign that requires a systematic approach to identify the underlying cause. The assessment involves history taking, physical examination and investigations. So today we are going to cover up definition, causes, assessment and key considerations regarding edema and Anasarca. Coming to the definition, edema means accumulation of excessive fluid in the interstitial space. And Anasarca is severe widespread generalized accumulation of fluid in various tissues and cavities. And interstitial fluid accumulation should be more than 3 liters to say Anasarca. Before going to the approach to an Anasarca or edema, you have to understand the total body water and the fluid compartments of the body. 2/3 of the body weight is comprised of total body water, and this total body water is divided into intracellular compartment, which is 2/3, and extracellular compartment, which is 1/3. And extracellular compartment is again divided into intravascular space comprising of plasma, that is 1/4 space of this compartment, and the interstitial space, that is occupying the 3/4 space of the extracellular compartment. And there is Starling force. So this force is regulating or balancing the fluid between the interstitial space and intravascular space. So disbalance of this Starling force will result in edema. Starling force are the forces which regulate exchange of fluid between plasma in the capillaries and the interstitial space, the one we had seen in the previous slide. So the factors or the Starling forces which are responsible are: number 1, increase capillary hydrostatic pressure; number 2, oncotic pressure; number 3, lymphatics. So let's see how the Starling forces is regulating the fluid exchange between those two compartments, that is plasma in the intravascular compartment and in the interstitial space. So if you see at the arterial end, the fluid filters into the interstitial space from the capillary due to elevated capillary hydrostatic pressure. Fluid is filtering out to the interstitial space. So this pink area is the interstitial space. And in the venous end, at the venous end of the capillary, this side, the fluid is returning back to the capillary from the interstitial space due to the increased oncotic pressure. And the fluid from the interstitial space is primarily taken up by the lymphatics, and it is flowing there. So this is the normal scenario. So if there is disbalance in this, the edema will result. So pathological processes or the imbalance which is leading to edema will be: number 1, increase hydrostatic pressure promotes filtration, and decrease oncotic pressure, number 2, it is impairing the reabsorption, so there is edema. Increase capillary permeability, there is leakage, so there will be edema. Fluid will move to the interstitial space. And lymphatic stasis, which will prevent the fluid removal from the interstitial space, so fluid will remain in the interstitial space, not draining into the lymphatics, resulting into the edema. So in brief, more filtration than reabsorption will be causing edema. Now come to edema in different diseases. So liver, kidney and heart disease will lead to edema. So in the liver disease, the main reason for edema will be portal hypertension, that is increased hydrostatic pressure; salt water retention, which is also leading to increased hydrostatic pressure; hypoalbuminemia, that is decreased oncotic pressure, is leading to edema and ascites. In the kidney disease, heavy protein loss and hypoalbuminemia, impaired renal perfusion will be the reason for edema. and in the hard cases, salt and water retention, ultimately leading to increased hydrostatic pressure, is the cause for edema. Now let's see individually about these Starling forces, in which condition, how it is causing edema. Systemic venous pressure increase is usually occurring in the right-sided heart failure and congestive heart failure, constrictive pericarditis. Local venous pressure increase is occurring in the left-sided heart failure, vena cava obstruction and portal vein obstruction. Reduced oncotic pressure is occurring due to hypoalbuminemia, and the conditions leading to hypoalbuminemia can be renal cause, that is in the nephrotic syndrome due to protein loss, and nutrition cause, protein energy malnutrition, that is due to decreased intake, and the liver cause, in case of cirrhosis, impaired synthesis of the albumin, so there is hypoalbuminemia. In protein losing enteropathy, that is the GI cause, gastrointestinal cause, here there is excessive loss of protein in the intestine, so ultimately leading to decreased albumin in the serum. And in case of burn, protein loss is through damaged skin. Increased capillary permeability and leakage is occurring in allergic and immune reactions like angioedema, where there is increased capillary leakage, and inflammation may be due to bacterial infection, septic shock, trauma and burns, there is increased leakage. And lymphatic obstruction is can occur in filariasis, where there is blockage of the lymphatic vessels by the parasites. Malignancy, the tumors will be obstructing the lymphatic flow, and in post-radiation there is damage to the lymphatic vessels, which results in the chronic edema, and post-surgery disrupts the lymphatic drainage, and then ultimately there is edema. And there are various causes where there is retention of sodium and fluid. So retention of sodium and fluid will ultimately causing increased hydrostatic pressure. So the conditions leading to sodium retention are drug induced by NSAIDs, antihypertensive drugs, hormonal excess like corticosteroids like in Cushing syndrome, and hyperaldosteronism, increased fluid retention. And conditions like syndrome of inappropriate ADS secretion or SIAD syndrome, here also there is sodium and water retention. And renal sodium retention occurs in renal failure where there is impairment of sodium excretion. Now come to different types of edema. Depending upon the site or distribution, it can be localized, that is occurring in the specific areas, and can be generalized, which is known as Anasarca, which is a widespread edema. And depending upon the nature of the edema, it can be pitting, that means it is leaving indentation when you press at the site of edema. Another is non-pitting, where there is no indentation, that occurs in myxedema. And special forms of edema, ascites, when there is accumulation of fluid in the peritoneal cavity only, that is ascites, that is a special form, and hydrothorax, that is accumulation of fluid in the pleural cavity. Now come to approach to the case. So when you approach to the case, you have to see the onset of edema. So if it is less than 72 hours duration, this is known as acute onset of edema, and acute onset can occur in allergic reactions, deep vein thrombosis, acute kidney injury and cardiac decompression. And then it can be chronic, that is onset taking duration of more than 72 hours will be considered as chronic onset or insidious onset. So this type of edema, if this type of edema is occurring, then you need to consider heart failure, liver disease or nephrotic syndrome. Then you look for the distribution, whether it is localized or generalized. If it is localized, then you think of venous or lymphatic obstruction occurring due to impaired drainage, and can be angioneurotic edema like from allergic reactions. And then if there is a infection, like example mumps leading to only parotid swelling, this is localized. And sometimes it can be due to lymphatic malformation, which is congenital condition known as Milroy's disease. Here also there is a localized swelling or localized edema. And distribution can be generalized. If it is generalized, you have to think of congestive heart failure in the heart cause. It can be nephrotic syndrome. It can be kwashiorkor, that is a protein energy malnutrition. It can be liver cause like cirrhosis. Then you come to evaluating the associated symptoms. If it is due to heart failure, patient will present with dyspnea, orthopnea, paroxysmal nocturnal dyspnea, cough, fainting, feeding, difficulties and sweating. And if it is nephrotic syndrome, patient will be complaining of frothy urine, periorbital edema, which was gradual or insidious onset and ultimately becoming generalized edema or Anasarca. If it is acute glomerulonephritis, patient will present with a hematuria, that is red colored urine, hypertension, high blood pressure, oliguria, that is less passing of urine. Urine output will be less. Then if it is GI and hepatic cause, patient will present with nausea, vomiting, jaundice, anorexia, abdominal pain and lethargy. If it is nutritional cause, then recurrent infections, night blindness can be the presentations. And some other presents due to some secondary disease conditions can be fever, joint pain, decreased appetite, failure to thrive, convulsions. So all these are symptoms of secondary causes or secondary diseases leading to edema. So after taking the symptoms, you have to evaluate the signs, associated signs. So in the cardiovascular system, the associated signs will be tachypnea, tachycardia, elevated JVP, cardiac murmurs, cyanosis, cool extremities, weak peripheral pulses, prolonged capillary refill time, gallop rhythm, hepatomegaly, wheezing. And if it is a renal conditions, then there might be raised blood pressure, periorbital edema, pericardial friction rub due to uremia. There can be hematuria, and all these signs will be pointing you towards renal condition. Then the associated signs for hepatic cause will be icterus, ascites, abdominal vein prominence, purpura, splenomegaly, feta hepaticus, metallic or fishy taste, palmar erythema, dupuytren's contracture, spider angioma, asterixis, male gynecomastia, signs of encephalopathy can be present. If it is a malnutrition, then the signs will be pallor, irritability, skin changes, hair changes, sign symptom of associated vitamin deficiency, especially vitamin A and zinc. And anthropometric measurements you are supposed to check. And malabsorption, if the malabsorption is caused, then foul smelling stools, diarrhea, history of cow's milk, and repeated infections, irritability, abdominal distension and clubbing can occur. Then you move to investigations. So diagnostic testing for cardiovascular system and renal system. In the cardiovascular system, start with the X-ray chest, where usually you can get the cardiac enlargement and features of heart failure like pulmonary edema. Then to detect for the heart diseases, you can go with the ECG and then finally echocardiogram. And if it is you are suspecting renal cause, then send the urine investigation in detail, like urine routine for microscopic examination, spot urinary protein creatinine ratio, 24-hour urinary protein, urine for culture and sensitivity. Then in the blood you can send serum cholesterol, serum complement, serum albumin, serum calcium for hypocalcemia and serum phosphate for hyperphosphatemia. And then you have to send the renal function test also. And many times you might have to send the complement levels. Then if it is a hepatic cause, then if you are suspecting hepatic cause, send liver enzymes which will be elevated, serum albumin is reduced and prothrombin time is raised. If it is you suspecting malabsorption, after examining the child, after checking the sign symptom, if you suspect malabsorption, then send for stool alpha antitrypsin, elevated serum IgE, reduced zinc and fetal fat estimation can be done. and some other general investigations for all the organ conditions. So all the edema, you can send complete blood count, that is you might get leukocytosis, eosinophilia, peripheral blood smear to see whether it is normocytic, microcytic or macrocytic anemia. Send the ESR, and then blood gas analysis may be required to check for respiratory alkalosis or metabolic acidosis, and then renal ultrasonogram can be done, and then ultimately invasive procedures like renal biopsy, and sometimes it is, if it is a chronic liver disease, hepatic liver biopsy also. Then approach to management in brief. So in brief, treatment of edema is never an emergency. Always start with the bed rest, limb elevation, and you should not hurry, but try to treat the cause. And then sodium restriction will be beneficial in heart failure and the nephrotic syndrome. And always try to use the diuretics very judiciously. Always remember, diuretics are not curative for edema. To cure edema, you have to treat the underlying disease. So while giving the diuretics, you have to be very careful. Extreme cautious should be taken while using these diuretics. Unless it is required, you will not use. So all cases of generalized edema cannot be treated with diuretics. Like example, in nephrotic syndrome, you should not use diuretics, because giving diuretics is going to aggravate the dehydration, because in the intravascular compartment there is already a compromised fluid, and fluid accumulation is in the interstitial space. So if you are giving a diuretic, you are increasing the fluid loss. That means intravascular compartment will be further compromised, and then the condition will deteriorate. So you have to be always careful, and always best is to identify the underlying cause and treat the underlying cause. So treatment of the underlying causes will be discussed when we are discussing the disease in brief later on. So this is in brief approach how you are supposed to treat the edema. So treatment part we'll discuss in detail later when we are discussing individual diseases. Okay, thank you for your attention. I hope you have understood the class. So next class we'll meet again with some other topic.